Good afternoon. It's my great honor to be invited here as one of the living legends in A-PHPBA. Before going into the main topic, let's take a quick look at the history of this meeting, A-PHPBA. The last meeting of this Congress was in Bengal, India, 2 years ago. And going back then, every 2 years, it was held in Jakarta, Seoul, Yokohama, Singapore, Shanghai, Melbourne, and Bangkok at this time. And 2 years before that, its first meeting was in my city, Fukuoka, Japan, where I was the first Congress president in 2007. According to the recommendation of Professor Takada, the founder of this meeting, and council members. Professor Igon Sachako was there as the next Congress president. So we are here in Bangkok again in 16 years. Therefore, I'm very honored to still be alive and well and have the opportunity to speak with all of you. Now, talking about the IPMN, the first case report in the world on IPMN were published from Japan in 1980 and 82. Note the picture of Dr. Ohashi and his mentor, Dr. Takagi. Both of them have already passed away, but should be remembered as the first in the world to discover IPMN. They called IPMN mucin-producing tumor of the pancreas at that time. This disease caught our attention because it had a unique characteristics. A large amount of mucus was repeatedly discharged from the angular bladder, causing an abnormal loosening of the sphincter body at that location, and was described with various names such as cystic adenocarcinoma of the pancreas, or mucin-secreting cancer, and so on. But the mucin-producing tumor was generally used for a long time in Japan. And over time, similar tumors presenting only in the branches of the pancreatic duct and the tumors with non-dilated ampulla were also reported. And many years later, the name of the disease was changed to IPMN and classified into 3 types as shown in this slide. This classification is important as the rate of malignancy is different between the branch duct type and other types. The main duct type and the mixed type are basically surgical indication due to the high rate of malignancy. However, the management of the branch duct type is controversial as it has a more indolent biological behavior. In 2006, the International Association of Pancreatology issued the International Consensus Guidelines for the management of IPMN and MCM based on a workshop in the IAP meeting in Sendai, Japan in 2004. It seems to me that these guidelines are well accepted worldwide as they can be applied to everyday daily practice. The IAP guidelines have been revised 3 times to date, with the most recent version published last year being the first to adopt an evidence-based approach. Each guideline is often nicknamed after the place of the meeting to draft it, such as Sendai, Fukuoka, Revised Fukuoka, or Kyoto. The Fukuoka guideline classified predictive signs into two categories to stratify the likelihood of malignancy, presenting three high-risk stigmata that suggest immediate resection, and seven worrisome features that recommend further evaluation by EUS. If there are no worrisome features, further initial testing is not recommended, but surveillance is still necessary. The revised OGA guideline had made some minor changes, limiting the enhanced solid component in high-risk stigmata to the size of 5 millimeter or more, and adding three factors shown in red. Into the worrisome features. The Kyoto guidelines added psychology to the list of high-risk stigmata and a new onset diabetes to the list of worrisome features. As can be seen, the EDM approach adopted in the Kyoto guidelines did not require major changes to the diagnostic criteria of IPMN. Because the tissue sample cannot be directly obtained from IPMN itself, the malignant transformation of IPMN can only be inferred using these diagnostic criteria. And the provisional diagnosis is relatively easy. However, a more difficult problem lies in the diagnosis of pancreatic cancer that coexists in IPMN patients. My big concern has arisen from our experience with the development of usual type pancreatic cancer in the pancreas of IPMN patients. We have experienced 122 patients with a concomitant pancreatic cancer in 1,000 consecutive patients with IPMN, not seen in our department. This represents as much as 12% of IPMN cases. Most of them are branch subtype, but the main subtype and the mixed type are also not exceptions. I began to experience the combination of a pancreatic cancer and the benign IPMN in this particular patient. This is the first case in the world where I found a carcinoma in situ concomitant with a small benign IPMN. Long before MRCT became available, balloon ERP was performed to visualize the old IPMN, and the cytology sample taken at that time came back positive. After I confirmed the origin of the positive cytology in the body or tail of the pancreas, I performed the fifth pancreatectomy. And after laparotomy, intraoperative segmental cytology again confirmed the origin of positive cytology, and complete histologic examination revealed a CIS in the branch close to a small benign IPMN after resection. And this is the second case that I found 1 year later. Carcinoma in situ was present in the main pancreatic duct, adjacent to the communicating branch to the benign IPMN. We reported this phenomenon as a sentinel for detection of carcinoma in situ of the pancreas. I will show you some schematic diagrams of typical cases. These are patients who underwent pancreatoglycinectomy for pancreatic cancer concomitant with IPMN. Number 12 and number 13 are examples of metacolons development of pancreatic cancer after resection of benign IPMN. You see the concomitant cancer occurred 2 years or 4 years after resection of the initial benign IPMN. And patient 14 and 19 developed a second pancreatic cancer after undergoing pancreatoglutenectomy to treat pancreatic cancer that occurred simultaneously with IPMN. These two cases also occurred within 5 years. However, please look at these patients who initially underwent distal pancreatectomy. In patient number 33 and 34, we found a carcinoma in situ in patient with IPMN in the tail of the pancreas, as I showed in detail before. We did distal pancreatectomy, but they developed a pancreatic cancer, second pancreatic cancer again, 7 years and 14 years later. Therefore, the occurrence of pancreatic cancer concomitant with IPMN and the development of new cancer in the pancreas remnant after resection of IPMN or synchronous cancer are another concern in the management of IPMN. These phenomena can occur over a very long period of time, not just within 5 years. Then, what is the best way to monitor IPMN? We need to be cautious of pancreatic cancer developing in patients with IPMN and follow up for a very long period of time. What I'm doing now is to repeat MRCT every 3 to 6 months. As MRCT can be performed repeatedly without any pain or radiation exposure, making it easy for patients to accept. While I'm not sure what the standard practice is in other hospitals or other countries, it is certainly true that careful consideration is necessary regarding the development of pancreatic cancer in all IPMN patients. So, what is the incidence rate of concomitant pancreatic cancer in patients with IPMN? The Japan Pancreas Society conducted a prospective observational study following more than 2,000 IPMN patients for a period of 5 years. The results showed that malignant progress of IPMN was 1.9% in 5 years, and the rate of concomitant pancreatic cancer was a little higher, 2.1% in 5 years. Therefore, the annual incidence rate of high-grade dysplasia or invasive cancer in IPMN patients was 0.37%, and that of concomitant pancreatic cancer was 0.41%. What do you think? Is this high or low? In conclusion, I believe that when monitoring a patient with IPMN, it is very important to always keep the concept of dual carcinogenesis in mind. All my clinical research activities up to now have only been possible thanks to the support of so many seniors, peers, juniors. As I conclude my lecture, I would like to express my sincere gratitude to all the members and fellow students of the Department of Surgery and Oncology at Kyushu University. Thank you for your attention.